with the experience from the West, from USA, as we said in the first of our introduction. And she will deliver, Barbara, a very interesting lecture about my favorite specialty, neuro surgery, neuroanesthesia. And Barbara is MD and Master of Business Operational Excellence and Fellow of American Society of Anesthesiologists, is an Associate Professor of Anesthesia in at the Ohio State Wexner Medical Center, Columbus, Ohio, USA. She specialized in the neuroanesthesia at the Tertiary Trauma Stroke Center, and she is a co-director of the Ohio State University Preoperative Assessment Center, where medically complex patients are optimized before surgery. She is actively involved in research, medical education, and serves on multiple local and national committees. She has a Master of Business Operational Excellence, as I mentioned, and is certified as a Six Sigma Black Belt. I think this belt is away from the karate belt.
Right.
Okay. Okay. And both from the Ohio University, Fisher College of Business. She is passionate about continuous process improvement, reducing waste, and improving flow in patient care activity. She will deliver a lecture for space occupying lesion, management of the brain tumor. So please, Barbara, floor is yours. Go ahead. Thank you.
Okay. Hello, everyone. Yeah, so my specialty is neuroanesthesia. So today I'm going to talk about just supratentorial brain tumors and anesthesia. I'm going to deliver a kind of a basic review lecture. So our objectives for this are going to be to state the most common type of supratentorial tumors, state the effects of PCO2 on cerebral brain perfusion, intracranial pressure, state the effects of the various anesthetic agents on cerebral perfusion, and rate the cerebral metabolic oxygen consumption, and list 3 ways to lower intracranial pressure during anesthesia. So what is supratentorial? Well, that is the area of the brain that is above the tentorium. So here's kind of a schematic picture. So most of the brain is actually above the tentorium. Below the tentorium is going to be your brain stem and your cerebellum. Things that may go wrong in the supratentorial area of the brain can be a primary brain cancer. You may have metastatic brain cancer, a hemorrhage, an infection, and these all may be intraaxial or extraaxial. Supratentorial brain tumors make up, the primary brain tumors in this area make up about 55 to 60% of the supratentorial tumors. Of these, gliomas make up 78% of adult malignant brain tumors. Gliomas rise from the glial cells of the brain. Glial cells can subdivide into different cells. They can divide into astrocytes, ependymal cells, oligodendroglial cells. There's also meningiomas that can occur in the supratentorial area. These are of the non-glial origin, and they make up about 15 to 18% of primary intracranial tumors. They're usually attached to the dura, and they're usually vascular tumors. There's also metastatic tumors that occur in the brain. Most commonly, these will be from melanoma, lung cancer, and breast cancer, although other types can occur also. So the World Health Organization, WHO, designation. So in 2016, WHO updated their classification of central nervous system tumors, and they added phenotype and genetic parameters to their definition. Previously, they had only used histologic data, classified these tumors. But still, if someone has a grade 1 WHO designated tumor, it's still the least malignant. And if you have a grade 4, it's still the most malignant. So this is a little bit more about the WHO grading system. So again, grade 1 tumors basically don't have any criteria. They're slow growing, they're non-malignant. Patients with these type of tumors usually have a positive long-term survival. Grade 2 tumors, they'll have one of the WHO criteria. They're still slow growing, but they may reoccur as a higher grade tumor. They can be malignant or non-malignant. Grade 3 type WHO tumors meet 2 criteria, such as they're anaplastic and or increased mitotic activity. They are usually malignant, and they often recur as higher grade tumors also. And the worst grade is grade 4. These tumors meet 3 to 4 of the criteria, and they are aggressive bad tumors. They're fast growing, they're malignant. So that's the worst type. Now we're going to talk about basic principles of neuroanesthesia. The most important thing, I think, when we talk about neuroanesthesia is the Monroe-Kelly doctrine. This is pretty much makes up all of how we do neuroanesthesia. So it's really important to review it and really understand it. So what this says is that the skull is a rigid container. And in this rigid container, you're going to have 3 components. You're going to have the tissue component, which makes up roughly 80% of the space. You're going to have the blood component that makes up about 12% of your space, and the cerebral spinal fluid component, which makes up about 8% of the space. Now, when you have a mass that starts growing in one of these components, because the skull is rigid and because all the parts have to equal 100%, if one part increases, obviously the other 2 parts have to decrease. And the brain has a capability of tolerating this and compensating to a point. So, but unfortunately, at some point, the brain will not tolerate it anymore. And all these compensatory mechanisms fail. And when this happens, the intracranial pressure arises abruptly. And the brain may herniate through different areas of the brain, and if the ICP is too high, and this is a medical emergency. This is a picture of the intracranial pressure volume curve. This is also a real important curve to remember when you're talking about anesthesia for patients with brain tumors. So what this shows on the bottom is that as the intracranial volume goes up, the pressure goes up. On the left-hand side, the pressure goes up. So as you can see, it kind of moves along with not much of a change, but at some point, and you don't actually know for each patient where this point is, the pressure will abruptly increase. Now I'm going to talk a little bit about the cerebral blood flow to the brain. The brain gets 15% of the cardiac output, but it is only 2% of the total body weight. The brain has a high metabolic rate of oxygen consumption, needs a lot of oxygen. The blood is supplied to the brain by the internal carotid arteries, which come off the common carotid arteries, and the vertebral arteries, which come off the subclavian arteries. So these go into the brain, and then they make something called the circle of Willis, which is an anastomosis of the terminal arterial branches. So this is kind of a picture of the circle of Willis. You can see there's anterior cerebral arteries, internal carotid arteries, posterior carotid arteries, and they're connecting vessels to connect them all. There's the anterior communicating artery and the posterior communicating artery. Now we have to talk about, as you get blood to the brain, there's something that you also have to remember, which is your cerebral perfusion pressure. So we have to keep a certain pressure in the brain so the brain tissue gets oxygen. So how you can calculate this is the mean arterial pressure minus the intracranial pressure, and or you can also use a CVP pressure. This can also be calculated if you don't have a MAP pressure, if you don't know what your mean arterial pressure is. This can be calculated by hand by taking your systolic pressure, subtracting off your diastolic pressure, dividing that number by 3, and adding on your diastolic pressure. That would give you a mean pressure. So this is an important concept to know what your cerebral perfusion pressure is. So the brain has cerebral autoregulation. So normally, Normal autoregulation will occur when your cerebral perfusion pressure is maintained between 50 to 180 millimeters of mercury. There's going to be some chemoregulation changes when your plasma CO2 kind of affects your cerebral vascular resistance. So hypercapnia, when you have high PCO2, this will dilate your cerebral arterioles and will increase your blood flow, which will increase your ICP. And the reverse is also true. If you have hypocapnia and you lower your PCO2, you'll cause vasoconstriction. This will decrease your cerebral blood flow and decrease your ICP. Now, if you have hypoxia, less than 50 millimeters of mercury, this will also increase your cerebral blood flow and your ICP. So if you have a patient, so that's a normal patient. If you have a patient with uncontrolled hypertension, their cerebral autoregulation, their curve is shifted to the right. So these people may have cerebral ischemia at pressures we normally would consider normal because they're used to such high pressure. So that's always something to remember if you have a patient with chronic hypertension that's really not treated, that they're going to need higher pressures than the normal patient. So their curve is gonna shift to the right. What that means is that when a normal patient may not have cerebral ischemia till their MAP or their cerebral automatic pressure is less than 50, these people might have it at 50 or 60 or 70. They need more pressure because they're used to higher blood pressure. This is kind of a schematic of all those things we just talked about: cerebral blood flow, percentage versus your perfusion pressure versus your PCO2 and your O2. So cerebral blood flow is on the left side. I wrote that in blue. And then all the pressures are along the bottom. I highlighted 50 to 150 because that's the perfusion pressure that will be a normal cerebral blood flow. And this is another graph that pops up in tests and things. And it's just a nice schematic to kind of remember how these all work together. Next, I'm just going to touch on cerebral spinal fluid. The normal volume of cerebral spinal fluid is about 100 to 150 milliliters. It's made in the choroid plexus and the cerebral ventricles. It's made at a rate of about 0.3 to 0.4 milliliters a minute. And then it's reabsorbed into the arachnoid villi, and then it goes back into the venous system. What is the role of cerebral spinal fluid? It's kind of the cushion for the brain. It surrounds the brain, the spinal cord cushions it. You will go through in 24 hours it will be renewed 4 to 5 times in a normal person. Normal cerebral spinal fluid has these components that I listed. Really, it's not important to memorize them all, but to know that you should not have bacteria, viruses, fungi, cancer, blood cells, and even white blood cells should be extremely rare in your cerebral spinal fluid, maybe less than 5. Now I'm going to talk about the angry brain. So when all these compensating mechanisms I discussed earlier, when they kind of have reached their limit and you're not compensating anymore, your increased intracranial pressure is not being mitigated by any reason, you may have these herniation syndromes. And these are the ones that are in the supratentorial type herniation syndromes. So the most common, or the one I always think of, is the uncle herniation, when the medial temporal lobe is squeezed by a unilateral mass across and under the tent-like tentorium that supports the temporal lobe. The subfalcine herniation, the cingulate gyrus is pushed under the falx cerebri by an expanding mass that's high in the cerebral hemisphere. And then you can also have central herniation. Both temporal lobes herniate through the tentorial notch because of the bilateral mass effect or some sort of diffuse edema of the brain. These are all bad. These are all emergencies. So what would you see? Well, for the uncle transtentorial herniation, the sign that's the most common, or probably the first sign, is you have unilateral pupil dilation, which we call a blown pupil. And that's because there's pressure on the parasympathetic nerve fibers of the third cranial nerve. Then you might start getting extraocular muscle paralysis and contralateral hemiplegia. Subfalcine herniation, you're gonna get small reactive pupils. It kind of traps, this herniation is going to trap the anterior cerebral artery, causing some contralateral leg paralysis. Of course, headache with all these, they're going to get headaches. In central, you get a fixed midline pupils, and you may have some decerebrate posturing. So now I'm going to talk a little bit about the anesthesia for these procedures. So the biggest goal of anesthesia basically is to save the brain from any secondary insult. It's already being insulted because you're doing surgery, and we want to keep it from having some sort of other insult during our anesthesia. So we want to reduce our ICP, or intracranial pressure. We want to optimize our perfusion pressure and decrease our metabolic rate of oxygen consumption, or the oxygen demand. So how can we do this? How can we lower our ICP? Well, the easiest way is to hyperventilate. So it's very easy if the patient's already intubated. If the patient is not intubated, you can make them hyperventilate before surgery if you felt that you needed to. But usually this is something we would do after they've been intubated. You would intubate them and hyperventilate them. And usually you get your PCO2s less than 30 is what we shoot for. This is a temporary measure. After 6 to 8 hours, our acid buffer system will revert and change the CO2 back to a normal level. So you can't do this like forever. It's very temporary. The next thing is positioning. So you're going to want to elevate the head of the bed. That maximizes venous drainage. You're also going to want to keep their head and neck in alignment, so you're not kinking off any of the veins in the neck. That lets the venous drainage occur. And medications. You can use furosemide, mannitol, 3% sodium, Decadron. Also, if it's really kind of a bad situation, the surgeon may also put in a CSF ventricular drain. That's actually, they put a burr hole through the skull and insert a little device that actually lets the CSF drain out, and that will lower the pressure in the brain. It's kind of temporary also. It won't last forever, but that's another thing they can do. So hyperventilation, we can have people, like I said, hyperventilate before induction. Once intubated, increase the respiratory rate to achieve PCO2 25 to 30 millimeters of mercury. Again, keep the head elevated, keep the neck and head straight. It's important to note if you change the position of the patient from sitting to flat and they automatically start vomiting, this is a really bad sign of increased intracranial pressure. You may see that. And our medications, I'm going to go over these again. So medications, furosemide. Furosemide is a loop diuretic. It acts in the ascending loop of Henle in the kidney, inhibits sodium potassium chloride co-transporter. It increases the loss of sodium, and water will follow. Mannitol is an osmotic diuretic. It will pull fluid into the vascular system by raising the plasma osmolality. This can also acutely alter your electrolytes if you give it too rapidly. You also want to use some caution with mannitol in patients with low ejection fractions, because as it pulls the fluid into the vascular system abruptly, this may lead to acute heart failure because these patients already have a low ejection fraction, and now it's almost like you just give them a big bolus of fluid. Same with 3% sodium infusion, this hypertonic solution. It pulls fluid into the vascular space to be excreted by the kidneys. It will raise your blood sodium level, and also you have to kind of be cautious with patients with cardiac patients, basically. And Decadron is a steroid. It reduces inflammation, and it's believed to decrease the swelling around brain tumors. Okay, so once you get our patient to sleep, we've done all that we just talked about. Now we're giving them volatile anesthetics. What's important to realize about these volatile anesthetics is that they will all increase your cerebral blood flow by vasodilation. They all do. This and secondarily will increase your intracranial pressure. They all decrease the cerebral metabolic rate of oxygen consumption, which is good. So typically what we do is we'll use less than 1 minimum MAC and hyperventilate to control vasodilation. It's hyper, not hypo. I put the wrong thing there. So that's kind of how you mitigate the fact that it increases vasodilation, but at the same time lowers metabolic oxygen consumption. The worst of these is halothane. I actually haven't seen halothane, but I don't know if it's used in other parts of the world. Halothane is the worst as far as increasing cerebral blood flow and vasodilation. Enflorane's in the middle. Isoflurane is the best of all three of those. And then sevoflurane and desflurane fit in around about the same as isoflurane as far as increasing cerebral blood flow. Nitric oxide is, the biggest problem with it is that it has a potential for pneumocephalus. You decide to use it, or if you decide not to use it, it does have that potential. IV agents that you can use, barbiturates such as pentothal lowers the metabolic rate of oxygen consumption of the brain. It suppresses neurotransmission. It's titratable for burst suppression on the EEG. The hypnotic propofol is very similar to pentothal. Others, such as etomidate, you could use this also, but it can cause adrenal suppression if you give multiple doses of it. IV narcotics. We commonly use IV narcotics during brain surgery to attenuate the sympathetic response to surgery. You're going to select what you want desired on the desired length of the action of the drug plus its half-life. Just remember that if you use something that has a long-acting narcotic, this may cause problems when you're trying to wake your patient up. They may have excessive sleepiness and you don't know if it's from what you gave or if there's a problem with their brain. So it's always something kind of to remember when you decide on what narcotics you're going to use during surgery and or after surgery. Remifentanil is kind of a newer drug. It's an ultra short-acting opioid. You give it as an IV infusion. It can cause bradycardia and hypotension. Also, there's fentanyl, sufentanil, and alfentanil. Sufentanil compared to fentanyl, it's rapidly eliminated from the tissue when you compare it to fentanyl, but it's more potent than fentanyl. Alfentanil is the less potent of the, it's least potent compared to fentanyl or sufentanil. You may have to give some seizure prophylactic medications. A lot of times these patients will have seizures before surgery. They possibly could have them after surgery. So you may be giving them at any time during the perioperative period. The thing to remember about seizures during surgery is that under general anesthesia, if you have a muscle paralytic on board, you're not going to see that the patient had a seizure. You're not going to know unless you have EEG monitoring at the time. So you may not know they had a seizure, and then at the end of surgery, we try to wake them up. They're post-ictal. They may not wake up very well. So that's kind of just something to keep in mind. There's different kinds of IV anti-seizure medicines you may be asked to give during surgery. I've listed those. I'm not going to really describe them all, but you may be asked to give these. So review. Our objectives today were as follows. State the most common type of supratentorial tumors. State the effects of PCO2 on cerebral brain perfusion and intracranial pressure. State the definition of the Monro-Kelly hypothesis. State the effects of various anesthetic agents on cerebral perfusion and the rate of cerebral metabolic oxygen consumption. And list 3 ways to lower intracranial pressure during anesthesia. So here we go. So number 1, what is the most common type of supratentorial tumor? We discussed earlier, glioma is the most common type. Number 2, what's the effect of PCO2 on cerebral perfusion and the intracranial pressure? There's a linear relationship. Increase there, as the PCO2 goes up, your cerebral perfusion also goes up. State the importance of the Monro-Kelly hypothesis. So that again is because the skull is rigid, there are 3 components. When one component goes up, the other 2 components have to go down to keep the pressure constant. Number 4, state the effects of various anesthetic agents on cerebral perfusion and the rate of cerebral metabolic oxygen consumption. The important thing here is that all volatiles will increase your cerebral blood flow and ICP, but decrease your metabolic rate of oxygen consumption. Cerebral blood flow effects can be attenuated with hyperventilation. IV induction agents will decrease cerebral blood flow and decrease your metabolic rate of oxygen consumption. List 3 ways to lower intracranial pressure during anesthesia. You can increase the head of the bed to facilitate venous drainage. You can hyperventilate the patient to lower your CO2, which will lower your ICP, and you can use different diuretics. Thank you. That's all.
Thank you. Thank you so much, Professor Barbara. Very informative lectures and for the basics of the neuro anesthesia. And I think there is no a great difference between our techniques in the East and as well as the West. I like neuro anesthesia, and I hope to meet physically together very soon after Corona. And I think we enjoyed in this scientific party this night because we had an experience of intensive care from Professor Ansari, and I think I can say the next lecture of Professor Hazem Yassin about the ethics and safety in the OR or administration. And lastly, we finished by Professor Barbara in the favorite for me, neuro anesthesia. So I'd like at the end to thank all the attendees and the panelists. And it was a very good and big dose of scientific meeting today. So thank you for everybody who shared, and thank you for the panelists. And now the floor for our leader, Professor Saad Mahdi. Thank you, sir.
Thank you very much, Professor Assam. I don't believe there is too many questions here tonight. Prof. Adil?
I think we have a question for Dr. Hazem about reporting the self-reporting. It is double sword, H as you said in the here, and what do you comment about that?
If I hear the question well, the question about self-reporting.
Medical errors and patient safety is an important topic, yes. But if you report according to the quality, if any yes. Problem or mishaps or anything, you should report self-reporting or no.
Yes.
And because the comment here is, as I said, it is double-edged sword. So what's your comment about this?
Yes, for the Joint Commission International last 2020, it encourages too much self-reporting, and it encouraged the administration of the healthcare organization to make safety culture and to get a just culture, to give all the healthcare providers the courage to self-report any adverse event or near miss, because by the analysis of this adverse effects and adverse events and the near miss, we can improve our organization, and we can prevent these next events and the near miss from happening again, and it will lead to more self-confidence for all the healthcare providers, and encourage others to share in this self-reporting. The culture of no harm. The new culture is no harm. So no punishment. Punishment is prohibited for any administration because it prevents all the providers to any report or about any event happening. I hope the question is clear.
Dr. Hazem, please. I have a question for you.
Yes, sir.
For the OVR, do you encourage the anesthesiologist to report for the OVR or incident reports for giving good chance for teaching, for learning, and for education, and to encourage them not to be afraid from the administration for speaking about any incidents happened, even if it is small. I think this is a good way for teaching and for learning. Do you agree with me of this?
Of course, Professor Manna, self-reporting for anesthesiologists is very important, and really it is a challenge because of maybe of our Middle East and Arab culture. The punishment and the legal aspects is preceding the educational aspects. Really, the main view is how to protect yourself. Maybe also our health organization is not giving us the comfort feeling of, if you reported about any problem, we will cover you, we will help you, our legal assistance will be on your back. So the juniors can report to the seniors, and the seniors will discuss with them about how this event happened, how we can prevent, how we can improve our performance. And really, during maybe 30 years ago, during my residency, I was afraid to report about wrong medication given. And then one of really my mentors and my great professors from Cairo University, he told me, if you afraid, how can you meet your God? If you afraid from me, what about our God? Very simply. So never afraid from me and not afraid from your God. Please, if you have any problem, report and ask the seniors and ask the more experts and get assistance. Never shy to get assistance. And so by this policy and by this protocol, please, we encourage quality-wise, Muslim-wise, doctors-wise, human-wise, to report about any medication error, any sentinel event, any near miss, so we can improve our performance.
Yes, we have a couple of questions for Professor Barbara, if you please. One of the question, does furosemide have a superiority over other diuretics, Prof?
No. Basically, with neuroanesthesia, you're going to pick your drugs based on what your goal is and what drugs are available. Unfortunately, in the world, there's lots of drug shortages every time you turn around. So I can't say that furosemide is better than some other diuretic that maybe somebody might have access to if they didn't have access to furosemide. So the basic concept is diuresis. So using a diuretic that you have that will get the fluid out of the patient is really the most important, not as much what the drug is.
Continuing with this question, are you using mannitol and be followed by diuretics or only mannitol?
So usually, honestly, what we do is we use Lasix, furosemide, 10 of furosemide, and we use mannitol at the same time. Basically, we push our furosemide 10, and then we give mannitol, usually half the weight of whatever your person's weight is in kilograms, we give half that. So if they're 70 kilograms, we give 35 grams of mannitol, and we infuse that afterwards. And this is really right after induction. So we put the patient to sleep. We have 2 IVs and an A line, and we immediately, once a person's asleep, start the mannitol. So I give the furosemide with all my induction drugs, and then the mannitol starts right away. So that the goal is, so when the surgeon opens the dura, the brain is sunken in. It doesn't puff out. You want the brain to be what they call relaxed, but it's kind of like a dehydrated brain. So when they're cutting open the dura, the brain is sunk in. So that's why we do it. So, and that's how I do it.
Okay, one more question about the timing of giving decadron or corticosteroids in the beginning or pre-operatively or intraoperative.
So
what is
your
the
patient.
advantage?
So your patient is going to have already seen the surgeon, obviously, and if they have a brain tumor, they're going to already be started on Decadron. That's like one of the first treatments the patient's going to have. So they're already on Decadron. So again, with induction, I usually give the 10 of Decadron, the 10 of Lasix with induction, with all my induction drugs, and then that will be continued by your surgeon post-op. But the patient's going to come in with that already unless it's an emergency and they hadn't seen anybody and they just showed up in the ER with this horrible brain tumor.
Is there any room for making rapid sequence intubation, especially in the COVID era now with succinylcholine?
With brain tumor patients, is that the question?
Yes, this is a question,
So that's a really good question. I think if a person is worried about their patient having COVID, then I think that's totally reasonable to do a rapid sequence. I mean, I guess we don't, right now there's opportunities to have rapid testing done before they come to surgery, which wasn't present back in April. And we were doing everybody rapid sequence unless we felt that we couldn't intubate them. We were really worried about it. There's, like a morbidly obese patient. So I think you have to take into consideration your patient population and how likely it is that you think this person might have COVID. Now, that being said, since we're a stroke center, now all our strokes are being intubated in the emergency room before they come up for thrombectomies. And that may be done everywhere, I don't know, but we are doing that. They're intubated before you can come in the room.
Can I comment, Professor Barbara? I think there is we are afraid from succinyl for the increased intracranial tension, especially in brain tumor patient. So we have also alternative to make rapid sequence intubation with the presence of rocuronium. If we give a big dose of rocuronium, and we have also standby and the reversal with sugammadex, so it is one of the alternatives to give rocuronium in case of presence of rocuronium and sugammadex in the institute. If we are afraid of increased intracranial tension by using succinylcholine.
Yes, that is true. I feel that the increased intracranial pressure with succinylcholine is theoretical. I've yet to see anyone herniate when I gave succinylcholine. So I kind of feel like that's a theoretical worry. That's my personal preference. So I would use succ if I'm really worried about their airway because it's so much quicker. If they just ate and I don't know, and if I really am worried about it, I use succinylcholine. The only reason I wouldn't use it on that patient would be if they had I don't know what their potassium is, they have a giant burn injury, or they came in and they're already paralyzed and don't move anything, and I'm worried about their potassium going up. But your point is well taken. Rocuronium you can reverse if you have sugammadex. So,
what do you think about the moderate hypothermia, 32 to 33? Is it applicable intraoperative or is more in the intensive care?
I think that's more of intensive care, or if you have like an actually devastating cerebral injury with the vessels. We actually don't do that at OSU for normal craniotomies. We don't make them very cold. But if you had like a patient that had a cardiac arrest and had a brain injury, yes, they do that in the ICU.
The last question I saw here about the allowed hypotension, and for how long do you allow for the hypotension during induction of anesthesia or maintenance as a compensation to increase intracranial tension?
I'm sorry, I misunderstood. The hypotension?
The hypotension. What is the allowed figure for the hypotension during anesthesia for patient with high blood pressure as a compensation for increased intracranial tension?
So you're always going to want so generally speaking, you're going to want your MAP, the mean arterial pressure, and all these people to be about 80, right? I mean, so if you keep it at 80, probably your hypertensive patients will not have a problem. It's when you let the mean arterial pressure go down to 50, which in a normal patient, that shouldn't be a problem. In a hypertensive patient, it will be a problem. So for induction and throughout all our brain surgeries and actually our back surgeries too, we keep our mean arterial pressures 80 and above. If we're really, really worried about perfusion in like a spine case, it may be even higher than that, maybe 90. So if you keep it at 80, everybody should be covered. And that's mean arterial pressure. Yeah.
Perfect. That's all I have. If anybody has any questions, he can go ahead. Thank you.
Prof. Roger, may I ask if you use hypertonic saline to reduce the intracranial pressure?
Do we use hypertonic saline to do what now?
To decrease the intracranial pressure.
we do that, you know, honestly, we only do that in cases where it's such a bad situation. Our first choice is always mannitol. If we've used mannitol and let's say they did a craniotomy, they went to the ICU and they're still having problems. Let's say they already put a burr hole in, they're draining CSF and it's still a problem. That's when they'll start the 3%. And usually they come in and get a craniectomy. They just take part of the skull off. So not normally, but under extreme circumstances, we do.
Thank you very much.
Dr. Hazem, please, I have one ethical questions.
Yes.
We have a accreditation committee coming to evaluate our hospital and our university. And as you know, we are preparing everything at the moment. And
yes.
all of the staffs and the OR, they are ready. And we are really continuing the same standard after they are leaving, but not like the moment they are coming to check for the evaluation. Yes. What do you think for how long or every when the committee should come to evaluate for the safety of the patient and for safety of the staffs?
Okay. Which committee?
Committee of credential committee, the evaluation for the hospital, evaluation for the process of the anesthesia OR.
Yes.
Like Cerebral. I mean, like Cerebral.
Yes, I understood from the question. It is an external surveillance.
Yes.
Okay. The main issue in the success in accreditation depends on the proper preparedness, and proper preparedness needs simulation, and needs a lot of drills, and needs a lot of internal surveyor stress, and needs checklists. First of all, delegate the continuous quality improvement and patient safety department should assign a competent, highly committed internal surveyors, and giving them the checklist with policies and procedures. And these candidate surveyors go smoothly to the staff, friendly, and try to make them share their experience, and try to delegate some of a selected, highly committed staff to help them in the survey. So the experience of the surveyors will be transferred spontaneously to the internal staff of anesthesia department, either consultants, registrars, residents, or even OR nurses and anesthesia technicians.
So it is a continuous process.
Yes. So it will speed the process. And repeating the survey and repeating the drill and simulations, it will help too much for everyone to get his rule and to rehearse his rule and to report what he did and to finish his documents needed.
Thank you, sir.
Thank you, sir. Thank you.
I'd like to thank Professor Samir Al-Ansari specifically, and I appreciate his presence with us, and all thanks for the speakers, and thank you so much, Professor Saad.
Thank you very much for all speakers tonight. Prof. Ansari, unlimited giving to us for his time and his for knowledge, and the library, Ansari Library, is fantastic resource for us, and Dr. Hazem Yassin, Prof. Barbara Roger, and Prof. Assam Manna, Prof. Adil, and thank you very much, Anna, and thank you very much, Mr. Dara Walsh, and for his excellent work with us tonight. And thank you much as this distinguished webinar tonight. And really, I enjoyed listening and working with you. Thank you very much, everybody. Thank you.